medial,
to
lateral medial side.
Half of the feet, so it enters medially, exits laterally. Then we have the AP oblique. Please write this down because this is an often missed point right here. We have two obliques that we're going to talk about. We do not do both these obliques per procedure. We do what the facility's protocol is. Some facilities prefer a 45-degree rotation, like the one I used to work at. Places like Harris Health prefer the Mortise rotation, which is a 15-degree rotation. Once again, it depends on the facility you work at or what the doctor in particular is wanting to see. Once again, we never do both, we do one or the other. Now, these last two are going to be our special views. So I would say 1 through 3 is our routines. The last 2 bullet points are going to be our specialized views that the doctor will order if they want to check things out further on the ankle. We have what's called the AP stress view and the AP weight bearing view. Now, it's not called a stress view because it stresses you out, although it may, but it's called a stress view because we're going to apply stress to that ankle to check the integrity of the ligaments in the ankle. Now, go ahead and make note of this because I'm going to see a lot of you raise your hand as the previous class did. But Mr. Donahue, I've done this one. Has anyone done a stress view in clinic? If you have not, don't ever do one. I'll tell you why. The AP stress view should never be performed by a technologist. That is a physician-only exam. Why? Because the amount of stress you apply to the ankle and the way you position it could actually tear the ligaments and further fracture the ankle if you don't know what you're doing. Therefore, that exam in particular, if it's ever ordered, you have to have the physician position it for you. Now, they may get grumpy and say, oh, or they may say, oh, it's fine, go ahead and do it. You can put my name on it. Don't do it. Don't do it. And we'll say again, don't do it. You're going to see texts do that. That's very dangerous to your licensure. If that patient were to get injured in that exam, you can risk losing your license over that, especially if a lawsuit was filed against you. So once again, big star, that is a physician-only exam, stress view. I guess it can stress you out a little bit, now that I talk about that one, but make sure you're not performing that yourself. Weight bearing you can do yourself. That's the same as the weight bearing feet, or just focus on the ankles. Yes?
If you're not allowed to do it, then why are we learning about it?
Wait, what?
If you're not allowed to do it,
why are we learning about it? Because it's going to come into your rooms, and if you didn't learn about it, you may actually accidentally do it. So let me ask you again, why would you need to learn about that? What are you going to do if that comes up on your order form?
I'm going to just say, I don't know.
Don't ever say, I don't know.
He's like, John, just get out.
But think about it. Let's say, you really didn't know and you just tried to do it anyway. You could actually make a huge mistake there. So you've got to learn how that's performed because you got to know to call the doctor and have them do that for you. So it is useful to know. I'm not just going to put useless info up here. You should know that by now.
So it's like a textbook thing. Like if it comes up as a question, it's like,
Position only.
Yeah.
We don't need to know the position. We just need to know that we don't need to do.
Oh, we need to know the position. We're going to get there. Because I'm going to tell you why. Because sometimes you have a resident that comes in and says, well, what do you need me to do? You've got to show him what to do even though you're not doing it. Yes. Oh, now it's making sense. Oh. All right. Now, I apologize, guys. I did not highlight the ankle slides with red, but I'll tell you what to focus on. That was a little oversight by me. But let's start with our AP ankle. Of course, we can do this supine or seated. Sometimes the patient can sit up on the table, a little more comfortable for them. This cannot be done in a chair. Why not? Well, look at how that ankle is situated. Can you do that in a chair while you're sitting down? Unless you prop the leg up on a stool, probably not going to happen. So this should be perfectly done on a table only. Of course, we're going to extend that extremity all the way out. Make sure that foot is pointed straight up. Very important. How many of you have done limp ankles out there? You can raise your hand. I'm not going to judge too much. You ever done a little limp ankle where it's just flopped over? Big no-no. You should never do that. Now, yes, the patient is in pain. They're going to be in pain when you position them for it. But you just tell them to get over it and shut up, and you do it anyway. I'll tell you why. Don't actually say that. That's just what goes in your head sometimes. Now, the reason why, because most of your radiologists, I say most, not all, will send that exam straight back to you if that foot is not dorsiflexed properly. Because if it's not flexed properly, they cannot view the ankle joint properly to make a proper diagnosis of the integrity of that ankle joint. So it's very important that you dorsiflex that foot all the way. Will they be crying in pain? Probably. They'll get over it. There's little strategies we can do to help them hold that in place. Most of the time, If a patient is having trouble, I will put a vest on, especially with kids, and just help them hold that ankle in place. I'll put my hand on the foot right here and just push it forward like this, or push it back towards them. Keep it that nice dorsiflex shape. If you don't want to be out there with the patient being exposed, you can give them a little sheet to pull their foot back, piece of tape, elastic band, whatever you have on hand to pull that foot back. Main point, once again though guys, you gotta make sure that foot is straight up, toes pointed to the ceiling. Now you can over dorsiflex. That would be as bad as the limp foot. They need to be straight up, not all the way back. Because if it's all the way back, you're gonna close that joint back off again. So the foot needs to be straight up, toes pointed to the ceiling. Make sense? Also, of course, your ankle centered correctly. Dorsiflexion, dorsiflexion, dorsiflexion. Put a big star on that, guys. Once again, and you can make note of this in your notes, anytime the ankle is anywhere in the vicinity of the film, we gotta have dorsiflexion, period. So let's say I'm doing a lateral calcaneus. Is my ankle joint on a lateral calcaneus? Yes, it is. So do I dorsiflex?
Yes.
Yes, I do. If I'm doing a lateral foot, is my ankle joint on that exam?
Yes.
So do I dorsiflex the foot?
Yes.
Yes, I do. If I'm doing lateral toes, is my ankle on that film?
No.
No. So do I dorsiflex the foot? No, I don't. You see how I can ask a question on that? Makes sense? So anytime that ankle is in the film, we're going to go ahead and dorsiflex that foot because the doctor will go ahead and analyze that ankle as well. Same with the tip fib we talked about. Tip fib, even though we're doing the whole lower leg, ankle's on the film, therefore I want to go ahead and dorsiflex that foot. Do not give me limp feet. Now, I'm sure y'all will run to Fung and Bonilla with your lower extremity x-rays. They're probably going to be as picky as me, though. Don't bring us those limp feet. We're going to call you out on that lack of dorsiflexion. You can tell very clear on that x-ray if it's not dorsiflex. Don't bring me any limp feet. I want that foot straight up in the air. It's very important.
It's just the fact that you're saying
Limp feet. What's what it reminds? It's like a limp foot, just flopped over. It's just a limp foot. Yeah. So perpendicular central ray, guys. As I said with the ankle, no angled tubes. Sigh of relief. Where are we going to put that central ray? Midway between both malleoli. What are the malleoli?
The side, the bus, the foot.
Incorrect. They are not on the foot. That's a common misconception. Where are the malleoli located?
Laterally. As well.
Lateral medial what?
Tibia.
Thank you, tibia and fibula. I'm glad you said that though, Shaheen, because that's a common misconception that people say the malleoli are the feet. Even though it's in the vicinity of the foot, it's actually on the tib fib, lateral and medial. Very important palpation point, and you can feel that on yourself. You're always going to palpate both sides of that leg. Put that central ray directly in the middle of the tube. That's going to be right on top of that ankle joint, as we see right here. And that's what we want to see, that nice, pretty open ankle joint. You'll notice we only see the ankle joint open from this section to the medial point. We do not see the lateral ankle joint opened. That's what we're going to achieve when we go to the obliques in just a minute. So for this one, we can only see the superior and medial section of the ankle joint. Boy, is that ever a good test question. Think so? Is that a good one? AP ankle, we can only see the superior and medial sections of the ankle joint. We cannot see the lateral section of the ankle joint. Of course, what else are we going to see, guys? The distal ends of the tib fib and the proximal portion of the talus. And the talus is one of the what? Tarsal bones. Tarsal bones. Correct. Now be careful on those markers. It's very easy to put your marker upside down, especially if you're looking at the cassette from this side over here. Make sure you match the marker with how it will be hung. Remember, the film will be hung with the tib fib pointed up. Therefore, your marker should be pointed up towards the tib fib. Does that make sense? What I'm trying to say? Also, do a walk around, guys. One common mistake people make on this is that they will do these ankle x-rays on the AP, and people will relax their foot on you. Put the foot straight up like this. They'll kind of like let their foot, well, first we'll do a limp foot like that. We don't want that limp foot. We want that nice dorsiflexion, but they'll relax their foot this way, and they'll relax it this way. Always do a good walk around, make sure it's nice and straight up. Otherwise, it's going to compromise your image. So you put the marker. So the right, with the right point up, you're going to match how the tib fib is going up.
Open those space.
Not right
See
in
where the finger is?
Just absorbing.
It's close.
So it's not leaning down. It's like how we normally.
Yes, I'm trying to put
It's
that
like
in
the
the words.
elbow is opposite, it's leaning down, but it's facing.
You want to match how you're hanging the film, and with the ankle, you're always hitting in it with the tip pointed up. There's markers to match that.
For an AP ankle, it's V1 to the left.
It's facing the patient.
Facing the patient, thank you. I couldn't put the right words.
So like the center and medial is open.
That's how we normally.
All right, so evaluation criteria, guys. Of course, good tight collimation. Don't open that collimation up. Some of your texts just get really slap happy and open that way up, and you can see like the whole leg on there. You can see down to the toes. You don't need all that on an ankle X-ray, guys. What's the star of the show? The ankle joint. Close that collimation up, please, for goodness sakes. Make sure your ankle joint is centered because it's the star of our show. We, of course, want the medial and lateral malleoli. Why? Because that's what we're palpating to put the ankle nice and centered to the film. We also, even though it's an ankle X-ray, we do want the talus on that X-ray. Please make note of that. The talus is a part of what?
The ankle.
Carpals.
There's tassels.
Oh dear.
That's how you said tassels.
Wait, what's the talus help form?
More
Ankle joint. Therefore, that is a part of that evaluation criteria. Know that. Like I said, guys, no rotation of the ankle. We should see the superior and medial sections of that ankle joint partially opened. That's what we're looking for. Like I said, tibio-talar joint space, interior tubercle. We're not worried about that. Talus will slightly overlap the distal fibula. That's okay. That's because that ankle joint on that side is closed. Main star of the show, once again, though, guys, superior and medial portions of that ankle joint. That's what we can see the best. Yes?
Question, like in a clinic, when we do ankles and they have surgery and rods and stuff, is it okay for them to open it up a little bit more?
Yes, that's a great point to bring up. The only time you're going to go ahead and open that collimation up is if there is hardware in the bone. And that's any part of the body, if there's hardware, you want to include the entire hardware. That's the only exception to that. Screws, rods, plates, all that stuff. All right, so let's go to our lateral ankle. Once again, what kind of projection? A mediolateral projection. We are going to turn towards the affected side. So we're going to lay on that affected side. And we're going to put the leg and ankle in a lateral position. Once again, what's the main thing we got to do? We got to dorsiflex that foot. So they're going to be screaming at you, but you got to tell them, I need you to flex that foot for me, sir or ma'am. Do you need any help flexing that foot? We're going to assist them in flexing that foot if they can't get it flexed. But it's ideal that we get that flexed as much as possible to open up that ankle joint properly for us. Once again, don't get any limp feet on there. I swear the lateral is the one I see the most limp feet. You can see it just all flopped over like that. Oh, it just like makes me cringe so hard when I see that. Can't stand it. Don't do it. How many techs do limp feet? Y'all see that? They just slap the foot up there and shoot it as is. Anybody see that? No one wants to admit to it? You can blame your tech, I don't care. Yeah.
It says turns towards the affected side. So what if the affected side is the opposite?
So in other words, if my right ankle is hurting, I'm going to turn towards the right. If my left ankle is hurting, I'm going to turn towards my left side. It's going to rotate the body that direction. That's what that's referring to. So if my left foot's hurting, I'm not going to turn my patient this way, obviously. Yeah.
Oh, it's just to remember that
Towards the
it's
side of
medial.
interest
Okay.
is how we're going to roll the patient. If we have to roll them at all, sometimes we just turn their leg like this. We don't have to roll them at all. We're going very flexible. Depends on the person.
So right ankle, turn to the right.
Just right.
It's always been
All right, so once again, a perpendicular central ray. We are going to enter a little bit different, guys. We're not going between. We're now entering directly on one of the malleoli. That's the medial malleolus of which we're putting our central ray. Very easy to find. We can palpate that quite easily. Just put your little crosshair directly on that little bump, and you're centered on the right spot. So perpendicular central ray into the medial malleolus. That's a test question there too. We enter the medial, we exit the lateral. Now what do we want to see in a true lateral? The lower third of the tibia, fibula, ankle joint, and the tarsals. And we also want to see the base of the fifth metatarsal. Y'all remember that one? That little protrusion? That tells us that we have the perfect collimation. We just want to see the base of it sticking out right here, which is what we see right here. Excuse me. Base of the fifth metatarsal. So even though the ankle joint is the star of the show, they want to see a little bit of that those tarsal bones as well. Of course, we're going to go ahead and see that calcaneus very nicely. So you can actually kind of kill two birds with one stone there. If they have calcaneus issues, you kind of get the same, you can get them both in one film, essentially. So if you had a good tech with some integrity, if you had a good tech with some integrity who was actually using their brain, and they ordered a ankle series and a calcaneus, you could do your 3-view ankle and then do the one plantodorsal calcaneus. Because is there any point in doing a lateral calcaneus? No, why? It's already on there. You'd just be re-exposing the patient. But you'd be surprised how many people don't think about that. It's, well, it's ordered, I'm just gonna do it, whatever. Think outside the box.
That's like a tip, like when they doctors order a tip fib and a knee.
Image redundancy is one of the biggest issues we have in imaging, and I really encourage you guys to recognize that. Always don't be afraid to call those people up and say, hey, you know, I know you ordered like the whole arm, but we can kind of like get some overlap. We don't need to do each of those individual, because you know, on a forearm we get wrist and elbow. Do we really need a separate elbow and separate wrist? Probably not. So you can usually talk them down to remove some of those orders. We just point that out to them. A lot of those young doctors or nurses usually put them in for them. Nurses really don't know. I'm going on a nurse tangent again. They just put whatever in there. Call them out on it. You know, stand up for your patient. You know, it's costing them money, and it's exposing them for no reason.
I did it for the, what's it called, when I was doing the thumb, they asked for a 3D and then they asked for a hand. So I did the hand and the finger as the
Very good. See, that's working smart. All right, guys, as with everything, we want that evidence of proper collimation, more so on the horizontal axis. Ankle joint should be centered to your film. We want to see that distal tib fib, the talus calcaneus, and the adjacent tarsals. Ankle should be in a nice lateral position. We should be able to see this tibio-talar joint well visualized. We will not if that foot is floppy. Remember, we don't want any floppy feet. That sounds funny, but you won't forget it. Dorsiflex that foot. It's going to open that tibio-talar or ankle joint nice and pretty for you. It makes that little half moon shape we see right there. That's what we want to see. We should also see the fibula over the posterior half of the tibia. So the fibula should be dipping down slightly there. Can y'all see the little outline of it? Right there. We also want the fifth metatarsal base and tuberosity. Why? Specifically to check for that Jones fracture. Did y'all learn about that pathology? That's how we're going to check for that Jones fracture, which is why they want that included on that film. Boy, that's a really good test question there. Feeling it. Feeling it. Can you feel it? Oh, I can feel it.
Feel it in the air. Feel it.
Y'all think I'm full of this, but I'm not.
Well, you
Right.
said it, we did.
You would think that, but.
Yeah, yeah.
That's a really important pathology to remember, by the way. I've seen that come up on registry reviews quite often.
Jones fracture?
The Jones fracture.
Whenever like we take the registry, like do you guys have access on seeing like what we answered?
I wish we did, but no. I can see your scores, but I can't see the actual questions. I'm the only one that ever knows that. That's confidential. I'm not allowed to share that with any. I can't even share that with other faculty. It's completely only for me. So no one will ever know.
Whether or not that y'all pass it, or we pass or fail.
Huh? Well, I depend on you guys to call and tell me because I like to know right away. But if you decide you don't want to tell me, I'll find out anyway. So if you say, yeah, I made a 99, I see it's like a 60, I'm gonna know. But I'm the only one that ever knows, so you can just, it's just be honest. It's fine. We're all gonna pass the first time though anyway, right? First time, right? We're not talking about this second or third, you know? No.
Yeah, I'm too broke for that.
Of course, guys, just to review, you should all know this is through pathology. There's that Jones fracture. It's a avulsion fracture specifically of